Okay, good afternoon. My name is Pieter Westerhuis. I am an instructor in the International Maitland Teaching Association, or called the IMTA, where we teach manual therapy courses according to the Maitland concept. One very important aspect in the Maitland concept is that assessment techniques are very often very similar as treatment techniques. And one also very important aspect are the so-called accessory movements of the neck. These are called the PAVMs, which stands for passive accessory intervertebral movement. I would like to focus today on the specific PAVMs we would perform in the upper cervical spine in patients who are suspected of having cervicogenic headache. Numerous studies have shown that these PAVMs are actually very reliable assessment tools, and they are very specific and sensitive in finding the symptomatic region. And also some recent RCTs have shown that when we do these PAVMs on patients with cervicogenic headache, they are actually very useful for the treatment. So if a patient is suspected of having cervicogenic headache, we want to find an impairment in mobility in one of the facet joints of the upper three segment. We would do unilateral PA on C3, both on the left and on the right. We would do the same on C2. We would do the same on C1. But then on C1 we have the speciality that we can now even go lateral to the joint, so we can do a unilateral PA on C1 lateral from the joint. Then we would position the patient in the sideline position, and we would do it transverse on C1. So let me show you on our nice model named EDU. So central PA on C3. Unilateral. Compare to the left side. Central PA on C2. Unilateral on the right. Compare to the left. Now on C2 there is also a nice differentiation we can perform. If there is symptoms with these PA, it may come from the C2-3 joint or from the C1-2 joint. I do not take my thumbs away. I invite the patient to rotate the head 30 degrees towards the left. Thereby, I increase the stress on the C1-2 joint. I do exactly the same PA movement. If the symptoms increase, that would support my hypothesis that the problem is coming from the C1-2 joint. If the symptoms more or less stay the same or even decrease a little bit, I would suspect that it is the C2-3 joint. So now, to get central PA over C1, I have to come from above. So central PA. Unilateral derecha, unilateral izquierda. Then this would be on the joint, over the joint. Now I go lateral of the joint. Unilateral on the left. And now I go lateral to the joint. So I am immediately behind the mastoid process. Now, Edu, de lado, por favor. In sideline, I position the neck in the mid position flexion extension. And now I do a transverse mobilization over C1. Now, of course, the findings of these tests have to be put in relation with your active movements and your pivots in the whole clinical reasoning process. If you find specific movement impairments with one of these pavements, exactly with the same techniques we would try to mobilize the segment. And as I said at the beginning, the effectiveness of these tests has been shown by studies done by Gwen Joel, by Ochoa, by Susan Reed. Thank you very much for your attention.